My name is Stefano Molica. I am an honorary professor at Al York Medical School in UK. And looking at the characteristics of patients with CLL that are candidate to receive treatment with BTKis, they are generally a population with about 72 years. And in this population, it is expected to observe an increase in the incidence of cardiovascular events. And we have an important trial that was performed at the Mayo Clinic, and this study, they tried to assess what was the risk of developing atrial fibrillation in a general population of CLL patients. About 1/3 of this patient did not receive treatment, and less than 3% of this patient received the Bruton as a part of treatment. So in this study, it was shown that the risk of developing atrial fibrillation, it was about 1% per year. And this study suggests us that in the context of this specific subset of patients, BTKi inhibitors are more likely to act as a triggers rather than through etiological causes of cardiovascular events. It is important also in patients with CLL, in this type of patient, to assess the cardiovascular risk. And we have some tools that are generally used for the general population, and they are adapted to the population with the CLL. However, it is important to underscore that these tools are not completely validated for CLL patients. So at the end, for assessing the risk, the cardiovascular risk, we prefer to use the only 3 factors, mainly the pre-existing atrial fibrillation, the valvular heart disease, and the hypertension. So putting it together, these 3 factors, we are able to define the risk of patient of developing cardiac complication during the therapy with BTKis. We have to consider also the role of other comorbidities that are often present in patients with CLL. I'm speaking about diabetes or dyslipidemia, and it is important also to consider polypharmacy. But when we have to start the therapy with BTKi in a patient with CLL, it's important at the beginning to assess what is the risk of developing toxicity. And for patients who have a high or moderate risk of cardiovascular risk, it is important to refer this patient to the cardiologist. And to share any type of decision with the cardiologist is also important. It's important also the early treatment of modifiable risk factors such as hypertension, because an early treatment of hypertension can mitigate the cardiovascular toxicity during the therapy. So patient should be also educated to report immediately any cardiovascular symptoms. And in terms of choice of therapy, as I said before, second generation BTKi should be preferred because it was demonstrated in phase 3 clinical trials a lower cardiovascular toxicity. And there are some patients that should not be treated with BTKis, and they are patients with a very high risk of developing cardiovascular complications. And for this patient, an association of venetoclax plus an anti-CD20 should be preferred.